Hello, hello, everybody. I'm Kenya Brown, and welcome to the chat where we bring community health and awareness. And we are speaking with Dr. Harris, who is an internist at the Cleveland Clinic and also the health chair of the Cleveland NAACP. How are you doing, Dr. Harris?
Good, Kenyon. Thank you. Thank
You
you. I'm
always
doing
have
pretty
some
good
great
today.
information for us.
Yeah, we try to share, we're trying to educate our community. There's no better community than the educated one.
Listen, I'm totally for it. And today
Mhm.
we'll be talking about AIDS and HIV. We're going to make some distinctions and get everybody all up to speed as to what we are doing or what is going on out here as far as AIDS and HIV. And
Mhm.
today we'll be talking with Dr. Dr. Georgina, who is the medical director of the AIDS Healthcare Foundation. Dr. Georgina?
Hi,
Hi, how are
Hi.
you?
Mhm.
I'm doing very good. I'm very happy to be with you today.
Yes, and you have a bunch of great information for us today,
Mhm.
right?
Yes.
All right.
Mhm.
So we're going to kick it off. We're going to talk about it and talk about AIDS today. And so, for those who may not know or may be a little bit fuzzy about what AIDS is, can you please give a little explanation as to what is AIDS?
Okay. So AIDS is mostly the disease that is caused by the HIV virus. The HIV virus, HIV stands for human immunodeficiency virus. Um, like all viruses, the way viruses work is that they're not capable of spreading or dividing or multiplying by themselves. They have to be inside cells. They have to infect a human cell, use it to multiply and make multiple copies of itself, and then burst out of the cell and killing it and just go and find other cells. So the HIV virus specifically attack one specific kind of cells in our body that are called T cells, that's the letter T, or what we call CD4 cells. So these are kind of immune cells that are part of our immune system. The immune system have a lot of different cells, but one of the important one are these CD4 cells, and the virus targets specifically the T cells. And by multiplying, it's going inside the cell, it's killing it, forming millions of copies of itself, and goes spread and goes to the next T cell, and so on. And by doing that process, it's actually killing an important soldier in our immune system, which we need to defend us against any kind of infection, pneumonia, skin infection, even defend against cancer cells in certain cases by killing cancer cells when they start multiplying. So when that happens, when the virus spread and kills a lot of the T cells and the T cell numbers start dropping, that's when you have AIDS because you lose a big part of your immune system. Um, so at the beginning, everybody has HIV. If they're not treated or they're not diagnosed, and the virus is working on their body, killing the cells, they develop AIDS, which is has two different ways to define it. The first way is if you have less than 200 T cells, by definition, you have AIDS. Or if you have what we call AIDS defining illness. This means specific illnesses that if you see them in a patient, you have to think of AIDS. For example, certain kind of skin cancer, like it's called Kaposi sarcoma, certain
Mhm.
kind of infections that we don't see in people who don't have immunodeficiencies, like certain kinds of pneumonia or fungal infection, infection by yeast, by mold, um,
Mhm.
tuberculosis. So there's a lot of diseases out there that, in case they are diagnosed, the first thing we think about is let's check for HIV. And other cancers, importantly, are lymphomas. So a diagnosis of lymphoma, the first thing you do is check an HIV status.
So, in general, what we're saying is the person has to have HIV before they can get AIDS.
Yes.
The HIV person, and we'll go over how they get AIDS and so forth and so on, and how they can protect themselves. So the distinction is a person has to have HIV first. An immunocompromised person is at high risk to get AIDS, especially if they don't take their medicine.
Yes.
And
Or they're not diagnosed.
or undiagnosed.
Yes.
And we're in
Yes.
primary care, we treat the same thing as a very population that with hypertension. We call it kind of a silent killer. So it kind of sneak around. So we got to be able to identify these particular people. Go ahead. How prevalent is this AIDS in our area? Tell us a little bit about that.
It's the most recent data I could find is actually from 2020. And in the whole state of Ohio, there were 897 cases in 2020 that were newly diagnosed with HIV. So these are, all the patient diagnosed, and most of them were centered in the big cities.
Mm.
That mean, Cleveland, Columbus, Cincinnati. So this is where most of the cases that are diagnosed. At this point in the United States, there is 1.2 million people living with HIV.
Wow.
Okay.
Hmm.
Out of these 1.2 million people estimate, there is 13% that they do not know that they have it.
Mm.
That's a lot.
That's 150,000 people who have HIV and they do not know that they have it. Hence the importance of screening and checking. I guess
very
Dr.
much.
Harris will agree with me with the push in the last few years to actually screen everybody.
Yes.
And check. And screening right now is very, very easy. Is like checking for your blood sugar. There's no big needles. There's no big blood being taken. It's just a pinprick. The result is there in a couple of minutes. And there is most of the institution, including ourselves in AHF and the Cleveland AIDS Task Force, we provide free testing. So you can just walk in many places and get tested for free. So, it is very important to get tested. And if you go and see your primary care physician once a year for your physical, make sure you ask for it. Or if you are offered, even if you think, no, why I don't have HIV, just check for it. Most insurances pay for it once a year. So just
150,000 people is quite a lot.
It is.
And me, internal medicine, it comes up on our annual health maintenance screen. So just like hepatitis C, at one point in time, we always have to check off, we need to know your HIV status. So if you come to any, at least the Cleveland Clinic, I think University Hospitals and Metro as well, just routinely, at some point in time, we need to know your HIV status, at least on the typical health maintenance, just like we need to know what your blood sugar is. Are you getting your annual flu vaccine, etc.? HIV is one of the items that we check for. 150,000 is a lot of people running around without us knowing that their status there, Kenya. That's pretty significant.
My question was, you guys okay, so you said that if your T cell count is below 200, then that means that. But for the average person, how do we know that those situations are going on, with us? Is it something that we should definitely just be like, when you go for your yearly physical, say, can you please screen me for HIV? Or is that how it works?
I would say if you, most people who have HIV are asymptomatic. The primary infection, this means when you first get the virus, when you first get infected, within that first couple of days, 2 weeks, there is a certain percentage of people, but not all of them, that will get like a flu-like symptom, which means you might have a fever, you might feel tired, you might have a couple of lymph nodes in your neck, like, you're having a sore throat. Some people might develop a rash. But it's very benign, and most people are like, I had the flu and I was sick for 2-3 days. Rarely people end up seeking medical help for what we call primary HIV. And then after that, it might take somewhere from 2 years to 10 years for you to develop AIDS.
Mm-hmm.
So you can be, feeling great, have no issues, and going around while the virus eats out on your immune system.
Wow.
That's one. So you're harming yourself. And two, you might be encountering other people and spreading the virus because you're not on treatment. So this
Right.
is where the 150,000 people mostly are. They're
Mm.
not aware that they have it. They don't have any symptoms. And you're not actually gonna develop symptoms until your CD4 count is less than 200. You might start having a pneumonia here and there. You might start losing weight. But no primary care physician or internist is going to check your T cell count.
No,
There
they
is no
check.
reason to check that
Right.
unless you have HIV.
Yeah. Especially in this day and age, especially you say flu-like symptoms. Typically what we do nowadays, we're checking people for COVID
Mm-hmm.
and the flu and RSV. So
Yes.
with those flu-like symptoms, that's kind of scary to know that could be a sign of HIV. But what are some of the risk factors should we look for in a person with HIV?
Well, the most of the people that are infected by HIV are infected through, at this point, they are infected through sexual contact.
Contact.
And men who have sex with men are they are the highest percentage of newly diagnosed, and it is the highest kind of risk just because of the kind of sexual contact that is happening.
Mm-hmm.
But any kind of sexual contact, you can get HIV.
Right.
But when it is a men who have sex with men, just due to the sexual contact itself, it's a little bit a higher chance of
Mhm.
transmitting the virus. But you can get it through, heterosexual sex. You can get it through oral sex. So
Yes.
this is the most common way. IV drug use and sharing needles is another risk factor because you are
Okay.
sharing blood products in
Mm-hmm.
a way, so you can get it that way. Drug use in general is looked at as a risk factor
Mm-hmm.
because drug use comes with being impaired, um, not remembering to use a condom, or um, using being prostituting yourself to get money or to get drugs.
Wow.
So drug use in general is looked as a risk factor. So we have to check people who we know that they are using drugs or they tell us use drugs. We check them for HIV a little bit,
Mm-hmm.
maybe more frequently than once a year, just because of the fact that by itself is a risk factor and might make you impaired or do something that you wouldn't do if you didn't use drugs.
Right, right. Does it disproportionately affect the African American men and women?
It does. And I'm going to just quote the numbers that I got out of the CDCs
Okay.
because we know that, at this point, most of the new HIV cases, new HIV is slowing down in most of the country. We have to look at that as a success story because newly diagnosed HIV is way less than when we were, 10 years ago or especially
Mhm.
30 years ago.
Yeah.
Um, there are areas in the countries that were not historically high on the radar of HIV. That's been,
Mhm.
like in the 90s and 80s and early 2000, it was the big cities like, New York, San Francisco, LA. Right now, the center of the pandemic is actually in the South. Uh,
Mm.
this is where most of the cases are. And it does affect mostly like the newly diagnosed cases.
Mhm.
82% of them are among men.
Mm.
So every year, like this is again the 2020 data that we have,
Mhm.
82% of the newly diagnosed are men, and 52% of them are Black and African American.
Oh, that's significant. That's,
That's very significant,
mhm. Mhm.
thinking about how much of the
Mhm.
general population is actually Black and African American.
Right. Right.
So
Right.
there's
So, what do you guys think is driving these disparities? In, I mean, we see racial disparities in so many different areas in healthcare. Why do you think that this is happening in this arena as well?
I think it's a lot of stuff. It's just part of the reason why why women, African American women who are pregnant are at high risk of complication.
Yes.
It's part of how the healthcare system is being managed. It's part of how the education in schools is being managed, in sexual education and educating people. um, it's just part of how the healthcare system is when it comes to this disparity that we see
Mhm.
in many diseases, not just in HIV.
That's right. Institutional bias. We see it
Yeah,
all over
we
Yeah.
see it,
place.
in maternal
Everything.
fetal. We see it in
Mhm.
diabetes. We see it in high blood pressure.
That's
Um,
correct.
so this access to care is very important. Um, and we try, and you want to reach out to this population where they are and educate them.
Yeah.
Mm.
At this point, at this day and age, we have the capability of having zero new HIV.
Wow.
Mhm.
That
Mhm.
is something that is tangible. You can um, have all the risk factor I listed above.
Mhm.
You can
Mhm.
you can be African American, be gay, use
Mhm.
drugs, and
Mhm.
100% protected against getting HIV. You
Yeah.
know,
Mhm.
we can
Uh,
get to that point.
yeah, that's the next question, or one of the questions. How does one protect themselves from getting HIV?
We do have what we call PrEP, or pre-exposure prophylaxis, and this is
Mhm.
the best way to keep stuff in a way in your own hands and keep your health something
Mhm.
that you manage, because sometimes you can be like, okay, I'm going to use condom at every time, but
Mhm.
your partner might decide that they don't want to use condom. So what PrEP is basically a pill that you take
Mhm.
every day
Okay.
that prevent you from getting HIV.
Oh, you
Hmm.
take it every day.
You take it every day. At this point,
Okay.
the
Mhm.
medication, the way it works best is to
Mhm.
take it every day. In the last year, we have the big breakthrough, which is an injection you take every 2 months,
Hmm.
and
Oh, yeah.
it protects you from HIV for the 2 months that after you get the injection. So
Mhm.
PrEP is the future. PrEP is available. The state of Ohio, and I worked in different states, have a
Mhm.
great program called PAPI, which, if you go to any kind of HIV clinic, they can help you enroll in it, which provide you these medication cost free.
Hmm.
Um, and at this point, I think they're only providing the pill, but it is a very, very safe pill. Doesn't cause any kind of side effect. You
Mm.
do need to be monitored while you are on it, because we're not treating you for something, we are preventing. So we want to make sure we're not causing harm. So you need to be seeing a doctor every 3 months. They check your kidney, your liver, screen you for HIV. But the medications are very effective. And now with this next step, which is injection, I mean, doctor visit every 2 months to get a
Mhm.
shot and be protected. Um, I don't think there's anything easier than that. Um, and
Not even condoms or something simple like that, or just
condoms do work,
okay.
but
Okay.
in there are situations where people don't use condom. You
Right.
know,
That's
oral
Absolutely.
right.
sex, people don't use condoms.
Yeah.
Hmm.
There are sometimes
They break, and
they break. Sometimes
they come off,
you
and
are high and you don't
that's right.
say that you want your partner to use a condom.
Hmm.
So that is a way for you, in a way, to take stuff into your own hands,
Okay.
and protect yourself. And I have so many patients on PrEP, and I have patients who have been on PrEP since PrEP started now 11, 12 years ago. And they have been on it for all this time. They don't have any side effect, and they are protected, even though they have all, they check all the boxes that they are high risk for HIV.
So
So
these are high risk people. This isn't actually treating HIV. This is actually, if you have high risk behavior, then
mhm.
you are taking this medication so that you will not develop HIV.
And I have patients, who, um, they are doing high risk behavior,
Yeah.
and at a certain point they find somebody, and they get engaged, they get married, and
Mhm.
they are in a committed relationship, and they come and they're like, at this point I'm gonna stop it, and I'm like, yeah, sure. And they do go ahead and stop it. If the relationship is successful, I never see them again, or I might see them in a year or two. But yes, in case you are exposing yourself, it's a way to
Mhm.
protect yourself, as long as you are doing any kind of behavior that is high risk.
Yeah.
Because in a way, you can ask somebody before any kind of contact, like, are you clean? Were you
Right.
checked?
Mhm.
And they
Right.
tell you yes, but how would you know? You know
I
what I
know.
mean?
Yeah.
You got to
Uh,
assume that they're
yeah,
not. You
yeah.
have to.
You have to. I mean,
Hmm.
I even have like people who are married,
Hmm.
and one partner is positive and the other partner is negative, and
Mm.
it's an extra layer of protection for the person who is negative to take PrEP, to take the
Yeah.
so they don't get it.
So does the insurance
Second,
company pay for that? I mean, or do they have to be related to like a spouse of a person that is HIV positive, or just period, just high
no.
risk or nothing?
Yeah, it's just I don't even have to document in a way, like in my note,
Hmm.
why they need
Okay.
it. Um,
Hmm.
Especially that the first medication that was approved, which is a Truvada, is now generic. So
Mm.
in
Okay.
most cases, we don't like. It's like you prescribing amlodipine for blood pressure.
Okay. Okay.
So you just prescribe it, and insurances just pay for it.
Okay.
You don't really have to have like a pre-approval or explain why this patient needed.
Well,
And as I said, if somebody has no insurance, they can be enrolled in the Ohio system, which is called PAPI, which once they are enrolled in it, will pay for the medication as well as a doctor visit every 3 months to get the testing done.
do they have to go to a specific clinic? You guys got federally funded clinics, or is there a stigma going to a specific clinic? Because, for example, in my office and other offices in the clinic, and maybe university and Metro as well, I mean, this is novel. I mean, we didn't even know, in a sense, that we knew it exists, but we thought it was just for the high risk community. I'm glad to see that it's not, and that we can prescribe it.
Yes. and
Hmm.
and I, and I it's one of these things that I think, um I always say, I wonder what I will do if we'll get to the point that we don't have any more HIV, because
Mm.
um first, we can get to this point if we get everybody who is at risk on medication and everybody who is infected on medication. We're not going to have new HIV. Maybe,
Hmm.
a generation down the line, we're not going to
Okay.
have the virus anymore. But yes, I mean, for me, it is like giving, as a primary care, and I am an internist too. So
Hmm.
giving, any kind of blood pressure pill, you
Oh, okay.
still want to see the patient, make sure that
Okay.
you're not
Right.
damaging their kidneys, because most blood pressure pill can cause, some issue in the
Side
kidney,
effects. That's
something in
right.
the liver. Most cholesterol pills, you have to check their liver function every
That's
so
correct.
often.
Hmm.
So this is something else that can be part of the primary care that is provided to the patient. And I think it's all part of how much a person or a doctor is comfortable,
Hmm.
because part of it is to education and STD screening, that's sexually transmitted diseases screening, because I always tell my patient, you're taking a pill to protect you from HIV. That is
Right.
not
Everything
good.
else.
Getting gonorrhea and getting chlamydia,
That's right. That's right.
syphilis, which is,
Hmm.
we can talk about, the issue we're having with these other STDs right now. For these other STDs at this point, you still have to use a condom.
That's right.
Um, so it is something that is manageable, and it's the future. Um, and this is something that I think I'm very passionate about,
Hmm.
because I see how good it is and how good it works, and how much advance that is out there when it comes to the medication. Going from Truvada, which is one pill once a day, all the way now to getting an injection, and looking
Hmm.
into the future where the injection time between injection is going to increase. They're going to look into having a different delivery of medication, for example, like we use the subcutaneous medication that you put under the skin for
Hmm.
contraception. We can use that same delivery method every 6 months, for example, to give you medication to protect you from HIV.
Hmm.
Good. So
So,
I'm
yeah,
sorry. On one hand, we are preventing a
Right.
person from getting HIV. On the other hand, HIV pretty much now is eminently treatable. Is that correct?
it is. It
Okay.
is.
Tell us a little bit
And
about that. Hmm.
it's it's amazing.
Hmm.
I was an infectious disease fellow starting 2010, and at
Mm.
that point we had only one medication that was one pill once a day, and it had horrible side effects.
Hmm.
But it was good because we went from making people take 30 pills a day in the 90s that they couldn't
Right.
tolerate it. It was like a handful of medication 3 times a day, to taking one pill once a day that had side effects, but they were not even comparable to the other medication, to
Mhm.
now having extra safe medication,
Mm.
um, with very rare side effects. Every medication you take is going to have side effects if you read,
That's right.
the label or see the commercial, because that's part of medication. I always tell people, I'm not giving you essential oils. I'm giving you a
Mm.
component that is a
That's right.
pharmaceutical that, might cause harm, but the benefit of it and the amount of harm is very minimal.
Yeah.
And once we get to the status that we call undetectable, you're basically managed and
Mhm.
completely having your disease under control. What we
Control.
mean by undetectable, that's mean we cannot detect the virus inside your blood.
Hmm.
And
Okay.
it is, whenever, let's say, you're recently diagnosed, and we check
Hmm.
what we call your viral load, which is the amount of HIV virus inside your blood. The number can range from tens of thousands to a million.
Hmm.
Um, but once you start medication with these new pills we have, which are all of them one pill once a day,
Hmm.
we're going down to undetectable. That's mean we cannot detect the virus in your blood
Okay.
within somewhere from 4 to 6 weeks.
Oh, that's
Now,
excellent.
do you so once you get to undetectable, is that a point where you can say, okay, I don't need any medication anymore, or is
No,
this still a lifelong?
it's a
Um,
lifelong, it's a chronic medical condition at this point. So
okay,
you have to take the pill every day. But one, the virus is not growing in your body anymore,
okay,
which means it cannot kill your T cells, it cannot harm your immune system. That is very important. Number two, you cannot transmit the virus. And
that's
this
good.
is this
Yeah,
is something that we can say out loud. If you are undetectable, you are untransmissible. What we
Right.
call U equals U, if you see the stuff
Hmm.
around, which means if I have HIV and I am undetectable, and I have sex with somebody who does not have HIV without protection, even without the other person being on PrEP, I cannot transmit the virus.
Well, that's excellent. So it's no cure per se.
No
It's
cure per
just
se.
okay, but you
But
can control it.
if you have high blood pressure and you
Mm-hmm.
stop taking your blood pressure pill,
Go straight up to the moon. That's right.
yes, and you
That's
might
right.
have a stroke, right?
That's right.
If you
Exactly.
have if you have
Hmm.
diabetes and you eat
Same
all the
thing.
Christmas cookies, And
That's
So you're
don't
gonna
right.
have to take it forever. You're gonna have to take that medication for a while.
Gotta take
but
it.
again, the future is bright, and we do have injectables right now for HIV, and it is an injection at this point every 2 months, which we know that it's gonna get easier and better. And
That's excellent.
medications are very, very effective. So we always say that if we can get every HIV positive person on treatment, they become undetectable, they cannot transmit the virus. So, in theory, we should not be getting new infections. If we can get everybody who is positive, including these 150,000 people that they don't know,
Mhm.
if we can get them on treatment, we're not going to
Right.
get we're not going to get, these 900 or so new Ohio cases every year.
Mhm.
Um, we're going to save life.
That's,
Eventually, in 2 or 3 generations, we can get to the point that, what is HIV? Um,
Wow.
mhm.
so it
That's
is not, we
incredible.
don't have a cure at this
Mhm.
point, but we
Mhm.
have a very safe, effective medications that, for
Mhm.
me, make HIV as manageable or even easier managed than
Mhm.
diabetes or high blood pressure. Um,
Yes.
it does bring stigma with it, but I always tell my patient, if you had diabetes, I'm going to tell you, stop eating sweets. And if you have high blood pressure, I'm going to tell you, watch your salt. All I'm telling you right now is just take this pill. Um, take it any time of the day. Just take it once a day. You don't have most of the pills. You don't have to eat when to take them. You can just, have it with you and take it whenever you want during the day. And it is effective and safe. Small pill, because, people think about pills and
Mhm.
large things. They're very small pills. And if you are into, you're okay with getting the injection, you come and see me every 2 months. I give you the shot and that's it.
Hmm.
So,
That's good. Mhm.
so yeah, it is a chronic medical issue, but,
Mhm.
you
But
know,
we have tools. We have tools. So
yeah,
status is very important. Coming out of this talk with you, everybody should know their status. What is your HIV? There's a bunch of people out here that could be positive. We just don't know.
yeah,
So everybody should know their own status because they don't want to give somebody something unwittingly. And
yes,
then number one, there's pills to keep you from getting HIV on one
yeah,
hand, and two, if you do get HIV, there are pills on the other side that will render the disease undetectable. So
yes.
we got good medicine. So compliance, just like in everything that we do, hypertension, diabetes, compliance is a significant issue. Do you guys find that as infectious disease consultants in treating PCP? And you guys treat most of the HIV patients, I take it. Do
Yes,
you find compliance to be a major issue?
it is. It is a major issue.
Mhm.
It's something that, you sit down with the patient, you ask them why you're not taking your pill. Nobody
Mhm.
tells me because it's causing me side effect.
Okay.
Nobody tells me it's
Mhm.
because it doesn't make me feel good. Most of the cases that I forget. I went on vacation, I didn't take my pills. I was using drugs and I forgot about taking my pill. um, we do
Mhm.
have other social issues going on sometime in this population,
Mhm.
including drug use or homelessness that prevent, if you don't have a stable home, you're not going to be capable
Mhm.
of keeping your medication and taking them every day. So there is a lot of challenges, social challenges that come when it comes to compliance,
Mhm.
um, and that we have to deal with. Mental health is another one,
Mhm.
um, that it is part of the general care that we have to provide to the patients, because if the patient is having mental health breakdown, they're not going
Mhm.
to be taking their pill, and that is risky on many levels. It's if you start the medication and you're not compliant with it, there's a risk of your disease progressing, there's a risk of you spreading the HIV, but there's a risk of, because of non-compliant, the virus is still there in your body. So it might actually learn how to become resistant to the medication, which
That's
is which is the thing we worry about with non-compliance. Because if you're taking the pill and then you stop taking it for like a week and then you start taking it again, the level of the medication in your body goes up and down, gives a chance to the virus to actually study the medication and
Hmm.
develop ways to be resistant, so the medication will stop working. And then we have to give you more medication, which makes your treatment a little bit more complicated.
Yes.
Oh, this is excellent. This is all great information. One other question: does people with HIV suffer disproportionately from COVID, since we are in a COVID environment the last few years?
Hmm.
I had,
Yeah,
Mhm.
most infections, any like streptococcus pneumonia,
Mhm.
any kind of infection is going to be a little bit worse
Mhm.
in an HIV positive person, just because your immune system, in a way, is all the time on the defensive because it has this virus there that is attacking it. So any
Right.
kind of other infection that might happen, the
You get
symptoms are
worse.
just going to be a little
Mhm.
bit more exaggerated. They are not
Right.
at high risk of getting the infection per
Mhm.
se, but once they get it, the immune response and the inflammation and the symptoms that come are going to be a little bit worse. So we did have, massive vaccination with COVID towards our patient, like we do for a lot of other diseases. Like, we vaccinate patients for pneumonia, like patients with asthma are vaccinated for pneumonia. So
Mhm.
they
That's
get the
right.
vaccine frequently.
Mhm.
We encourage, flu vaccines, hepatitis vaccines, because anytime they encounter these infection, the response of their body is going to be worse. So we want to make sure that they are protected as much as possible.
Good. Good. And there's association also with the monkeypox, with that high risk grouping as well, and make
That-
sure that they get all of that as well too. I
That's true.
assume.
It's just because of the population where um, mpox started spreading. Um,
Mhm.
that's the same population where HIV is common.
Right.
And again, it's just the way mpox started spreading in the men who have sex with men population,
Mhm.
which we did vaccinate most of our patients. We did have a couple of cases, unfortunately, that we treated, but it's just part of the fact that, for example, we check for other sexually transmitted disease frequently in our HIV patients, just because of the fact that you have these risk factors.
Risk factors. Excellent.
Now, I know that you mentioned that you were excited about the injectables that you guys have. So, is a vaccine on the way for AIDS?
Well, believe it or not, the COVID vaccine, the technology used to work on the COVID vaccine is actually first was started as part of the HIV vaccination. And
Really?
right now they're looking into it again. They're
Mhm.
looking at this messenger RNA technology in science, trying to see if we can, use that to create vaccine. I'm
Mhm.
not, I'm not a research doctor, but I know that this is something in
Mhm.
the works, because that's going to be like, the big breakthrough, because you get the vaccine and that's it, you're protected. You don't have to take prep, you don't have to take anything else. So it is something in the work. I know there's a lot of people working on it. I didn't see anything tangible when it comes to actually having any kind of human um, research, like actually testing something on human at this point. So it's probably down the line many years, um, but it is something that it's being looked at.
Wow, that's
Oh,
awesome. And tell us some resources, sites that people can get some of this information. You've given us a wealth of information
yes, she
about
has.
and
Mhm.
HIV, but where can some of our viewers and listeners go to find out more information?
Um, the CDC website is great. You could just go CDC HIV, or the website is cdc.gov or hiv.gov, and you can find a lot of resources, information, statistics. I do encourage people to actually come and visit us in the clinic, and I'm not using this as publicity, but we do have a lot of groups and resources available through the AIDS Task Force of Greater Cleveland, where there are specific groups that are related to the risk factor. Men who have sex with men, African American who are at risk and have questions. I am there available too for education, not just to treat people and give them medication. Um, and we do have a lot of trained people in the task force, social workers and educators that can give the information and answer questions. And while doing that too, provide free testing.
And where is the clinic? Where
It's
the
on Euclid.
Okay.
It's on Euclid Avenue. The exact address is 2829 Euclid Avenue. It's something that anybody can walk in and ask questions. We do have a lot of educators available to answer questions. I am there in case somebody have any questions. And again, testing is free.
Okay.
It's anonymous, and I always say, just get tested. If you are
Yes.
positive, we will manage it. We'll hold your hand. It's a shock when it is positive. It's nothing that anybody wants to hear,
Yeah.
Right.
but it is just another chronic medical problem that is manageable. So we just have to take stuff step by step. There's no need to be scared about being tested and being positive. I would be more scared to have the disease and not know about it.
Yeah.
That's right. That's right. That's excellent. So what was once a we used to think was a death sentence, now there's hope.
There is hope,
We
and
have
life
mhm,
expectancy is very similar. That means, if
mhm.
there are two twins, one of them
Okay.
have HIV and one
One don't.
not, they're gonna live. If the person who's HIV positive is on treatment, they're gonna have the same life expectancy
That's
as
right.
their twin who does not have it. There's more doctors visit. There's more testing being done. There's
Mhm,
more, involvement of the healthcare, screening you more for cancer, screening you more for this and that, just as a
mhm.
prevention. But there is these images that are still in the memory of people of the 80s, and you know
Right.
in the movies where they
Life
show
is
you.
over with. Yes.
Yeah,
It was
Right.
yeah, that's not anymore the case. It's
Good.
very rarely that we have what we call full-blown AIDS with the weight loss and the pneumonias and the skin lesions.
Mhm.
We rarely see that anymore, and thank God we don't see that.
yeah.
But it's better to
Education is
know and get
powerful.
treated. It's like going and having a mammogram.
Yeah.
Mhm.
We're all scared when we go and have that first mammogram. What if they're gonna find cancer? Well, if they find cancer early enough, it's gonna be curable and easy to manage. So
We always tell people we want to know, and getting back to our primary care theme, and know your numbers. Know
mhm.
what your blood sugar, your blood pressure, your cholesterol. Now we
Yeah.
added another thing here: know your age status. So
Yes.
'cause there are active medicines to prevent you from getting HIV, and if you do get it, unfortunately, the good thing is we have medicines that can treat it and make your disease undetectable and keep your livelihood the same as anybody else's. So
Yes. Yes.
thank you very much for joining us on our health chat this month. This is a very tough topic. Some people don't like to talk about it, but it's especially prevalent in our community and disproportionately so. So we probably all know somebody who have or close to someone who pretty much have been exposed to this thing. So this is something that we need to be able to talk freely about because there is medicines and treatments. Thank you, Dr. A.
I want to add one more statistic, and
Yes.
just
Mm-hmm.
because we are two women here against you, Dr. Harris.
Okay. All right.
I said that 52% of
Mm-hmm.
the newly diagnosed are African American. But the other big diagnosis is, there's a very small percentage of women who get HIV, but out of the women who have who are newly diagnosed with HIV,
Mhm.
60% of them are African American women.
Oh boy. Wow.
So, you know, just get tested, get on treatment. If you think you're doing anything that's putting you at risk, just reach out to any healthcare worker, your doctor, your gynecologist. They will know where to send you. The treatment is easy. The prevention is easy. Just ask the questions. And I always tell people, if you come to me and because you're thinking of getting on PrEP, it doesn't mean I'm going to force you to be on it. I'm just going to answer your questions and let you take the decision yourself. But it's important to get the information from the right people.
Knowledge is so powerful, and we get a chance to talk to great doctors like Dr. Harris, Dr. Georgina, who have a wealth of information. So make sure you share these videos, because we have rarely get this much time to talk to such esteemed doctors in their field, and you want to know that status, and they're giving you information that, even if you're not going specifically to them to advocate for yourself when you go to your own physician. So definitely share this video, because even if it's not information that you can use, someone else can use this information and it could be life-changing for them. So thank you so much, Dr. Harris, as
Thank
always.
you. All right.
For this great wealth of information. Dr. Georgina, thank you so much, guys.
Thank you. All right. We'll see you. Happy holidays, everyone.
Happy
Happy
holidays.
holidays. I'm Kenya Brown. Till next time.
Bye-bye.
Thank you, Kenya.
Bye-bye.
Bye-bye.